The immunosuppressive drug I chose is tacrolimus. The structure is shown there, and it's also known as Prograf, Abigraf, and other names that are commonly used. It's an immunosuppressive drug that's used in the prevention of organ transplant rejection, specifically in kidney transplants. It was first discovered in the late 1980s, and it was discovered by isolating it from fermentation broth of soil bacterium. And its introduction marked a significant advancement in the field of transplant medicine because it provided a powerful alternative to existing immunosuppressive therapies. And it's a macrolide lactone, which is similar to another immunosuppressant called cyclosporine, but it's more potent and requires lower dosages than that one does. So it targets specific pathways, such as the T cell activation pathway. This one's fundamental to the body's immune response. So T cell activation begins when T cell receptors on the surface of T cells recognize and bind to specific antigens presented by antigen-presenting cells. And so this triggers a series of intracellular signaling cascades, which ultimately increases intracellular calcium levels. So the elevated calcium ions then bind to calmodulin, which is a regulatory protein, and that forms a calcium calmodulin complex that activates calcineurin, which is a phosphatase enzyme. So the activated calcineurin dephosphorylates the nuclear factor of activated T cells, which is also called NFAT, which is a transcription factor. And NFAT translocates to the nucleus of the T cell and initiates the transcription of genes that are essential for T cell activation, proliferation, and cytokine production. And this includes IL-2, which is a key growth factor for T cells. The mechanism that tacrolimus uses is it binds to an intracellular protein known as FK506 binding protein 12, and it forms a complex that's a potent inhibitor of calcineurin. And so by inhibiting calcineurin, this complex prevents the dephosphorylation of NFAT, so it remains phosphorylated and is then unable to translocate to the nucleus. So without the nuclear translocation, the transcription of IL-2 and other cytokines necessary for T cell activation and proliferation are both blocked. So this inhibition ultimately halts the early activation signals in T cells and prevents their proliferation and differentiation, which are both very crucial for an effective immune response. Tacrolimus also is able to effectively downregulate the immune system by inhibiting the calcineurin NFAT pathway. So the suppression of IL-2 production is pretty significant because IL-2 is essential for the growth, differentiation, and survival of T cells, like mentioned before. So without IL-2, proliferation is then reduced for T cells, and that leads to fewer activated T cells in circulation. So this reduction in T cell activity then diminishes the body's ability to have an immune response against perceived threats, such as transplanted organs. So for kidney transplants, this is pretty crucial for preventing the immune system from recognizing the transplanted kidney as foreign and attacking it, which would then lead to organ rejection. So by selectively targeting and inhibiting the calcineurin pathway, tacrolimus is able to control and modulate the immune response, which ensures longevity and functionality of transplanted organs while also minimizing the risk of rejection. Now, there are some downsides to tacrolimus, such as when it comes to its clinical use, or its use in clinical practice, it has a narrow therapeutic index, which means that the difference between the therapeutic dose and toxic dose is pretty small. So blood levels of tacrolimus must be closely monitored to ensure that they remain within the target range that provides the effective immunosuppression while still minimizing adverse effects. The drug is metabolized primarily by the liver enzyme CYP3A4, and its pharmacokinetics can be influenced by genetic variations in this enzyme and by interactions with other drugs. There are some side effects as well. Nephrotoxicity can occur, which is kidney damage, which is very problematic in kidney transplant patients. Neurotoxicity as well, which can be seen as tremors, headaches, or seizures. Hyperglycemia, which can lead to diabetes mellitus, And hypertension is the increased risk of infections due to the suppression of the immune system. Also, long-term use of tacrolimus can increase the risk of developing cancers such as skin cancer and lymphoma. And this is also due to the chronic immunosuppression. And so managing these side effects requires careful dosing, monitoring, and sometimes additional medications to mitigate the specific adverse effects. As mentioned before, it can interact with other drugs, which could either increase its toxicity or reduce its efficiency. So drugs that inhibit the enzyme, such as certain antifungals and antibiotics like those two, can increase tacrolimus levels and the risk of toxicity. But drugs that induce the enzyme, such as rifampin and certain anticonvulsants like phenytoin, can reduce tacrolimus levels and its immunosuppressive effect. So in conclusion, tacrolimus is essential in preventing organ rejection in kidney transplant patients by effectively suppressing the immune response through inhibition of the calcineurin NFAT pathway. There are some side effects and risk factors involved in the use of it, but there are also some benefits from it. So continued research aims to enhance the safety and efficiency of tacrolimus through improved formulations, novel delivery systems, and better management of its pharmacokinetics and side effects. So that would ultimately just improve the patient adherence and outcomes and just the overall performance of tacrolimus. And these are my sources.